Hi, good morning, everybody.
Good morning.
Hello, hi.
Hi, how are we doing?
Good, how are you?
Very well, thank you. Very well. Looking forward to the session.
So my colleagues are joining in as well.
Hi, good morning to everyone who's just joined. Greetings, Mila. All right, I think we're going to wait for another couple of minutes, everybody, just for other people to join, and then we can kick off. All right, Gail, what do you think? Should we get started? Right.
I don't think that anyone else from our side will join. I see Anna and Ludmila has joined already, so that's it from our side.
Okay, no problem. We're also recording the session, so anybody who can't join, we can send the video recording to you. So, Anna.
Okay, thank you.
Okay, great. Well, welcome everybody to today's Ask Me Anything with Simone Carter. We're delighted to have Simone with us. So I'll introduce Simone in a second to you all. But just to start with a little bit of housekeeping. So before we dive into, I'm just going to start by diving into an outline of exactly what we're going to be doing today. So we're going to have a 1-minute kickoff session with Simone to kind of get her into the flow of the question and answer session. We'll then hand Simone the mic for 10 minutes so she can introduce herself and the CASS system in the DRC. And then we're going to have a 30-minute question and answer session. So most of you who are on the call today, I think were in the previous Ask Me Anything with Sid, so you know how this works. But we have this rather obnoxious clock that shows up in the session, which is here to kind of keep us on time. Let's keep us respecting time. I know a lot of you have got questions for Simone, so we just want to make sure we've got the opportunity for Simone to answer most of your questions. The session is being recorded, so don't feel obligated to keep your camera on, but of course we'll be very happy to see all of your faces in the session today. So without further ado, I will introduce Simone very quickly, and then we'll go into the 1-minute Q&A before handing it to Simone the mic. So we're delighted to introduce you to Simone today. We're really excited for this call. Simone is leading on the Integrated Outbreak Analytics for UNICEF's Public Health Emergencies team globally. And she's also responsible for having set up and is still running the Social Sciences Analytics Cell, which is called the CASS. If we hear the CASS, that's what we're talking about today in the DRC. So Simone will go into much more detail about what the CASS is, but just as a very quick overview, the Social Science Analytics Cell, or the CASS, is a mechanism really operating in support of the Ministry of Health in the DRC to provide real-time operational evidence to inform public health and outbreak response. So the mechanism brings together multiple data sources, including epidemiological data, health services data, qualitative and quantitative social sciences evidence, contextual data, for example, socioeconomic and population data, together with programs data. And it's been an especially useful system to guide the behavioural response to the DRC's most recent Ebola outbreak. It really provides this holistic picture of what's going on at the community level to support effective programmatic decisions. So where we've heard a lot of you say that the behaviour and social sciences data is often neglected next to more epidemiological or biomedical data, this CASS system, which Simone's going to present and talk to you about today, really aims to fill this gap and to ensure that this data is really systematically considered. So we thought, in response to a lot of your questions today, that by listening to Simone, she could be an inspiration for you all, especially as I know a lot of you on the call today are thinking about setting up your own information hubs in countries. So you can think about how you can collect data more systematically at the community level, and also learn from Simone about how she did this, how she got buy-in from different political figures in countries too. So without further ado, Simone will speak in a second about the CASS model, but maybe I can set up and just have a quick 1 minute Q&A. So Simone, are you ready for this?
Yes.
Great. So I'm going to start the timer in a second. So our first question for you in this quick 1 minute is, can you choose 3 words or phrases to tell us how the CASS has transformed Ebola programs in the DRC? I'm going to start the timer now.
Yeah, thanks. Improved access to services, specifically vaccination for pregnant and breastfeeding women and children, adapted, appropriate, and more effective communication materials, and improved engagement with women and youth, mostly through the use of evidence.
Mm-hmm. Great, so fast already, I love it. So what's the most consistent solution you'd say that the CASS has helped to identify in the DRC?
Yeah, that's a funny one. I think most of the time what we're seeing is the evidence shows that the people who need to change, we have this kind of big thing ongoing, like behavior change and community behavior change and behavior change communication. And actually the majority of the behavior change needs to come from us as humanitarian response actors, whether that be Minister of Health, UNICEF, WHO, or NGOs. The change is really on our side. And we can talk about that a little bit more later, but that's really the consistent. Oh, that is
Absolutely
a big timer.
Perfect. That response was literally nipped in at 0. So well done. That's really great. So that's just to kind of get you into the flavor of things. We're going to come back to this obnoxious timer in a second. But first off, Simone, I'm going to hand you the mic just to introduce yourself to all the colleagues, UNICEF colleagues on the call today, and to tell us a little bit more about the CASS system. And then we can go into the Q&A, if that's okay. So if okay with you, I'll hand you the mic for about 5 to 10 minutes.
Perfect, thanks. So hi, everyone. My name's Simone. I'm an epidemiologist, but I'm what we would call now a social epidemiologist. So I have been working in the DRC since September 2018, where I came to support on the Ebola response. And the CASS was really something that was set up very organically. So responded to what is really was that we had lots of epi data. You know, the epi data has become prettier, sexier, more graphs, more models, more information, but without an ability to actually explain what this means and why. So we were seeing higher numbers of children, for example, under 5 that were affected with Ebola, but we couldn't understand what the reason for that was. We're very quick to say women are disproportionately affected because of their role as caregivers, but we weren't recommended because they weren't eligible. And so what we started to do was say, okay, we need to understand the causes and the barriers and enablers, causes of high risk practice, driving factors behind transmission. And so we started doing qualitative analysis. To be clear, at the beginning, there was me and NGO hygiene promoters who were doing the data collection. So this is from Oxfam, from IRC, from MedAir as well, who were supporting in doing the data collection on different days and really supporting on the questions. For example, MedAir was working in a healthcare facility where they were seeing cases come by and not being referred to the Ebola treatment center. So they asked us to support to explain what was happening there. And we did a barrier analysis and understood again that it was the responsibility of the response teams who weren't picking up the telephone when they were calling for an alert, et cetera. But so we were working with the NGOs, working with different actors from the NGOs to collect data to better explain the outbreak dynamics. And in January 2019, so about 6 months in, January, February, we hired a group of local researchers from the different areas to start to do this more systematically. We developed terms of reference, which were signed off by the Minister of Health. So that also includes in the Ebola response, the INRB. So that's those who lead on all the ethical research in the country as well. So we had terms of reference that allowed us to sit next to the epidemiological cell and provide this integrated evidence systematically to the response. We set up teams. So one of the really unique things is we set up teams at the field locations. So Beni and Butembo is an 2-hour drive between the two, but we had teams from those two different areas staying in those areas. So the idea was that they would collect data specifically to that granular level of that location, and then presenting the results systematically as well to that location. So they were trusted by communities because they're from the communities. They weren't seen because of the response with the response in support of response teams' questions at a local level. It wasn't coming top down. In June 2019, so less than a year after we'd started doing this work, we held workshops across all of the different response coordination levels to define how we could monitor the use of evidence. Because great, studies are sexy. We love the evidence. We've got so much of it, but how do we actually make sure that we're using it? And how do we demonstrate that all this data collection is appropriate and is effective? And so we, through different workshops and a series of working groups with response actors, NGOs, and local government, we decided on setting up something called the Monito, which is a tracking tool, which allows us to track the amount of co-developed recommendations by study, by location, over time. And so we present results, but we don't tell response actors what to do. So we don't imply that we are the WASH experts. What we do is work with the WASH team to develop the kind of IPC commission, whatever, to define the kinds of questions they need, to get the answers, and then to present the recommendation or the results together and code recommendations. We decide together what are the indicators, and we help them follow that up. Then we feed that back to them, because so this is how we're changing. So it becomes a really supportive and positive process. So that existed for all of the Ebola outbreak, integrated with epidemiological data. Also using health services. So that's other health, looking at increased all of that kind of more integrated data as well. And then we were shutting down and saying, okay, now the outbreak is over. We don't need to continue to collect data. And COVID happened. And so the Minister of Health asked us to set up a similar structure where they had an integrated outbreak analytics cell through what they call the Commission de Gestion des Informations, so an integrated information commission, with health services use data, so Ministry of Health data, with epidemiological data, and with social sciences integrated data. And we then brought together all kinds of socioeconomic, population movement, timelines, events, et cetera, data as well. We have since in the DRC as a methodology for the plague, as a kind of cell and methodology for cholera, and then the cell structure for COVID. We've also then replicated successfully in the Guinea Ebola outbreak in 2021. We set up an integrated outbreak analytics cell as well for the Ebola response there. It was set up within the space of 10 days. It was one of the first times where, there was no discussion of whether social sciences sits where and what kind of data. It was everybody sitting together, everybody looking at data holistically. And we now do this at a global level. Sorry, there's a plane going overhead. I apologize, I'm in Eastern DRC. And so Like that. It's a helicopter. I'm sorry. And then what we have done now is set this up at a global level. So we have CDC, WHO, UNICEF, and MSF Epicent, plus academic partners who are setting this up as a global structure to be able to support countries everywhere in this kind of work and have a network of trained people who can do this kind of work. So Sirisha, I stop there.
Yeah, I think that's absolutely perfect. Thank you so much, Simone. So much interesting information just then, and I know there's so many questions that all of our participants have got for you, kind of coming off this. So what we'll do right now then is dive straight into the Q&A, I think. For all of you who are listening on the call, we already have a lot of really great questions that have come in through VaxChat for Simone. So I will start by asking some of those questions from VaxChat. But if anything that Simone says has just said is really triggering any questions for any information you'd like to know to be applied in your own context, please just put the questions into the chat, and then we'll incorporate these questions into the Q&A as well. So the way this is going to work, Simone, is I'll ask you a question. We'll have a 2-minute timer on the clock, and then you can try and do your best to respond in 2 minutes. I know it gets very tricky and we can have a break halfway through because you'll probably just need a glass of water, but we can do our best and see how this goes. Okay, brilliant. So I will kick off then. So the first question we have here is, what makes the CASS unique? So they've put in, for instance, is it the strategic level influence? Is it integrated service? Is it the coordination, collaboration with the Ministry of Health? Is the direct link to the epi analysis? So to you, what do you think makes this system unique? I'm going to start the obnoxious clock.
Thanks. Yeah, so, and I will also cite, we had Oxford University and Wellcome Trust come and evaluate how it works and what are those unique aspects. So some of what I'm saying is also coming from that evaluation. It's a bit of everything. So we tell the teams all the time that it's 50% quality work, 50% integration and being able to look at data holistically, but it's also 50% how we treat and engage with people. That could be the Minister of Health, that could be NGO partners. If you're not able to communicate results in a way that is digestible for the person who's going to use them, you're not going to get buy-in. If you're not going to be able to adapt and present across multiple forum and engage and not attack, come in with a lot of humility in especially in discussions that might be sensitive, that kind of all that interpersonal communication about how we work with data is equally important. Another huge factor is that we have no branding. So imagine, yes, UNICEF. We do not have UNICEF branding. There is no UNICEF colors. There is no UNICEF logo unless we have all of the partner logos at the end, and that include, and everybody's at the same size. None of this like UNICEF and the minister is bigger and everybody else is tiny. No, everybody's logos at the same size at the end, and everything is done in like a neutral color. And I know my teams are exhausted with seeing gray and what they call depressing colors, but those are the things that keep everybody feeling like it's co-owned. We are co-branded, we are co-owned. When something is produced by the CASS or by Integrated Outbreak Analytics, IOA, it is done for partners, and that's how you get everybody using it. So it's really critical for us to ensure that component. And lastly is that we don't ask questions that we don't know that can be used. So we really focus on what is usable and including the actors in the development. We're ready to say we won't do something if somebody else is doing it. I think sometimes often in research, we're obsessed, I see 4 seconds, we're obsessed with collecting new data. But if some...
You can finish the sentence, don't worry.
But if somebody is already doing it, we always find an excuse of why we need to do it as well. And actually we don't. What we'll say is somebody else is doing it, we leave it.
That's brilliant. Thank you so much, Simone. I loved what you just said about having humility as well and interpersonal communication. That really that people factor, I think, is something that we can probably dive into in another question later on. And the co-ownership and collaboration approach there too. It's really inspiring. So congrats, that's amazing work. Okay, the next question we have that's come in is, who makes up the CASS team? What type of skills do they have? What types of backgrounds and expertise? And how are the government involved? So you've got about 4 questions in that one. So maybe we can just ask generally, who is in the CASS team? And then you can speak to it. And I will start the timer now.
Okay, so as mentioned, I'm an epidemiologist, but most of the team are integrated social sciences. They have experience for training from London School of Hygiene, Tropical Medicine, or other integrated social sciences. So we stay away. No, we have some anthropological background, but typically that then comes from a biomedical anthropology. We have epidemiologists, but then they also have to have the social sciences. It is a unique training point. But more important than that is actually people who have worked in outbreak response. Because data collection is one thing, being a great researcher is one thing, but if you don't know how to use that data, it's not the objective of how we work. The objective of how we work is using data, so you need to know program. And so all of us have experience working in, we have a lot of ex-MSF in the team, have experience working in that. We work then with the Ministry of Health, of course. So we respond directly to the Director General of the general direction of the fight against illness or disease, in I don't know how to say that in English. And so everything that we do through them. We have now, for example, for COVID, a broad ethics umbrella for everything that we look at that covers broader impacts of COVID on communities across the country that we have done together with the Minister of Health and INRB and the School of Kinshasa School of Public Health. So we make sure that that is an equal partnership, not something that they just sign off for. Then we work with local researchers, as mentioned, so everybody from the area. I mean, right now in the country, we're 3 internationals, and I work part-time as well for the global team. So we're a small international team and a large national and local researchers. And those teams, they also present to the local Minister of Health. So when we do healthcare worker surveys, those results are presented at the local healthcare or health zone level. Making sure that that data is owned, making sure that the government is, the local Minister of Health is looking at the data tools and looking at the results and supporting the co-development of actions.
Look at that. That was literally perfect timing. Well done. That was really, really great. And there's such really rich information there. As a background, a lot of the colleagues in the call today are looking at setting up in quite similar cells in their own country too. So understanding who is part of that team, understanding how you've got the Ministry of Health brought in, understanding how you've got the local research teams as well incorporated, I think will be such useful information for them. So thank you for that. That's really great information. Okay, the next question we have here is, can you give some examples of how the CASS has led to effective policy and program decision making based on real-time social and behavioral data? And I will start the clock now.
Yeah. Yes, sir. Yeah, sorry. So I think one of the first ones is on changing all of the during Ebola, is that what people were calling misinformation, which was actually miscommunication of Ebola symptoms. So posters, communication material, radio messages, everything with hemorrhagic symptoms or wet symptoms, which actually evidence indicates, so epidemiological evidence and biomedical evidence indicates that those are not the most common symptoms of Ebola. They're not what first presents. And social sciences evidence indicates that people, for example, were much more willing to go seek healthcare, but they didn't know, they weren't being informed, provided information with the correct symptoms. So through integrated analysis based on understanding delayed treatment seeking, causes of the present, we changed all the communication materials to talk much more about light symptoms. Probably my most proud important change is that we changed the access of vaccination for pregnant and breastfeeding women. So this was a long 9-month advocacy process, but what we did make sure is women who were breastfeeding, who were unable to access the vaccine, first-line responders, so people who are absolutely at huge risk of exposure of Ebola. And we're very pro breastfeeding, but in those kind of cases, we need to be providing actually options for women to stop breastfeeding and to have a kit and to support non-breast milk, non-breastfeeding for the child. And that was actually done so that women could access the vaccine while we waited for the vaccine policy to change, which is huge, especially in terms of women's rights. In terms of COVID, we worked with all of the different partners to collate all of the data across the country on the impacts of school closures, and we were able to reopen schools.
Amazing. Thank you so much. That is honestly unbelievable timing. I think also just so everyone knows in the call, Simone has very kindly shared some really good slides which shows what the CASS is, as well as how it's had an influence on decision making. So those will be available also on Vax chat after this really great session as well. Just so you all know, I know it's a lot of information that's been thrown at you. Okay, Simone, are you ready for the next question? Okay, so the next question is, how is the data and information coordinated and shared between key stakeholders at various levels in the DRC?
Okay, yeah. So a lot of different data sources, right? So, I mean, we can share some slides later about but we could look at 50 different data sources for looking at the impacts of COVID on women and girls, for example. We have strong partnerships, as in the teams are consistently, these are not formal partnerships. These are not written pro-docs or whatever with UNICEF. These are actually just like networks of us calling and discussing and sharing. When we then develop any kind of PowerPoint presentation or a brief note, that is then shared back with the partner so that they make sure that what we're saying is correct. They have to sign off on it if we're using their data. We then make sure that everything is available, open access. We use Google Drive. Google Drive is not what everybody loves, but it is what the Minister of Health uses. And this is why we use it, because it is the tool that they use. So we can have all the discussion we want about data sharing, but that is their tool and we support it. We then make sure that everything goes back to them. If we have anything that is sensitive issue, so excess mortality data, infection data, nosocomial infection data, et cetera, we will go back and check with the responsible for the Minister of Health first. What's next? Oh yeah, so we share across all of the tools, all of the raw data. So raw data is cleaned. Obviously, no unique identifiers are ever taken, so that's not a problem. And all of the presentations has a webpage as well. At a global level, we're now working on how to do that through the GORE Knowledge Hub, so that tools will also be available on there. We then will get things now. So for example, DKT, who asks our teams if we can help them analyze their data. Mary Stopes as well will ask us if we can help them analyze their data. So we do those kinds of different.
I've just lost Simone. Simone is calling from Goma today, so she will hopefully be back in just a second. So we can have a brief pause that she probably needs anyway. Simone, can you hear us? Oh, there you are.
Sorry.
No problem at all. You're tackling the internet challenges and all these questions extremely well. So well done. So while we had that last question, which was super, super interesting to hear your answer to, and really understanding how you've tailored the response as well to make sure it aligns to the Ministry of Health and what they're doing to make it really usable for them, I think that was a really key takeaway from me for that last point. We've had a lot of questions that just come in for all our participants in the chat. So I'm just going to switch to a question that's coming in from the chat now. The first one is, can you please elaborate on who is funding the cell, the experts, and the research work itself?
Yeah, so at the beginning of the Ebola outbreak, UNICEF direct funds, and then they took like a little bit from all the different donors. So what we come under is like program quality. So we would get funds. We are not, I mean, to give an example, the DRC, UNICEF has a budget of $1 million a day. We have a budget of $1 million a year at max. And so it's a very different budget, but now we are funded by the middle of the Ebola response. The Swiss, the Swedish, FCDO, USAID, and CDC all funded. In addition, what's important to notice is, for example, CDC wanted to send somebody to work inside the CASS, right? So they then deployed somebody on a $1 contract who was paid by CDC, who then supported the team, and who then I was able to manage through these like $1 contracts where it's like a secondment. Now for COVID, it depends. So cholera, ECHO will fund us as a proper section, and we exist as a section in UNICEF in the DRC. And so we write proposals the same way the other sections do, integrated. And the aim is that with the sections in the DRC, we say really the aim is that we go first and try to do the understanding and then influence. But that funding comes through for ECHO, for the Japanese, et cetera, USAID. There's not actually a donor that says no, the World Bank as well. At a global level, so what we just set up, so I've just come back from a week in Geneva working at this global integrated outbreak analytics. So then we have been supported by the Wellcome Trust and FCDO to try and set this up. We presented last week to Mike Ryan, so the director of WHO, who has committed, at least verbally, committed to funding this for the next 2 years to making it set up. But what we will be looking through is each individual organization and our different donor opportunities, again, the CDC, all of the usual suspects, to fund that support at a global level equally.
And you've done it before the timer ends. That is fantastic. That's brilliant, and congratulations again, Simone, for that agreement from Mike Ryan. I think it's a really amazing achievement, and it shows the value of this initiative a lot. So yeah, congratulations for that. The next question that's come in, I don't know how you're going to answer in 2 minutes, but I'm going to wish you the best of luck to answer this in 2 minutes. We had a 45-minute presentation on this recently, so let's do our best. This one's on sustainability. So someone's asked, how are the national or local authorities either taking over the model, or how is it integrated into national systems? So basically they're asking what happens if UNICEF and other international organizations stop supporting? How sustainable will the model be? So I'll start the timer. Let's see how much you can get through.
It's a really great question. So, and this is, this is an evolutive process. At the end of Ebola, I really felt that this was something that should stop. I felt like it was something that we come in an emergency, we set up a cell this way. We do not need to argue all the time to exist, right? We do as much capacity building training as possible, but at the end, we don't need to justify having a whole bunch of internationals always here to do research, right? Then the actual request came from the Minister of Health and from UNICEF to continue to have this kind of support. There is some critical components that take a lot of time. So I think those things of, you don't capacity build in 6 months. You also don't capacity build when you have a full-time job. One of the things that we saw in the integrated outbreak analytics cell is in Guinea, as well as in the DRC, is at the same time as we're supposed to be doing analytics, we're supposed to be training on how to do. And that's almost impossible if you're already a short-staffed team. So what we are trying to do at a global level is have that fund where we are really setting up systematic training and capacity building to do it. Recognizing that these things are things that take 2 to 5 years, not things that take 6 months. In the DRC, for example, now we have somebody who runs interrupted time series analyses, so particular analyses on healthcare services use. That person's in the University of Hong Kong. Now I'm working to find somebody in the Ministry of Health who we can pay the person in Hong Kong to train somebody in the Ministry of Health to do. But those relationships, they take huge amount of time. If we're not sitting here consistently, especially when you're talking about integrating social sciences data and looking holistically, right? Even in UNICEF, the behavior change to understand the use of that kind of data, it's a long process. Yeah. But we have to also consistently go, is it worth it? Are we actually able to, is what we're doing even having an impact? And if not, is it justified? So that's as well where it comes to making sure that we are setting up mechanisms to really evaluate ourselves consistently and go, is this where we need to be going? But we will be working, we are working on trainings. We do work hand in hand with the Ministry of Health. We do to provide them all the training. But if UNICEF pulled out right now, or if everybody stopped doing it, I think there would remain some individual capacity, but it doesn't mean that the system would remain. That said, just if I can very quickly, in Guinea, the Minister of Health, they knew what had been done in DRC, and they were like, let's go, we want an integrated cell. There was no question. They wanted to work that way. So we don't have to have it always fixed, but the fact that we know that when we have an Ebola outbreak, this is the mechanism. It's in the strategic response plan for the Ministry of Health in Guinea right away. It was in WHO's strategic response plan for all of the West Africa 2021 Ebola outbreak stuff. So it is influencing in that sustainable way in terms of how we write strategy.
No, congratulations for getting through that in about 2.5 minutes. I'm sure you have so much more to say. We'll probably get a lot more questions on that as well. But I think that's a really, really great response. And I thought your point about how really capacity building whilst also doing the response, is very difficult to do. And I think over time, seeing that people are really valuing this data and changing their mindset, as you say, it can't be done in 3 months, 6 months, especially when you've got an outbreak ongoing. But seeing the value of it over time, I think that's a really important thing that I've just gotten from that. So thank you very much, Simone. These are really powerful insights. The next question, which I know you'll have a good response to, we've gotten from the chat, is can we ask Simone if or how she's using the system to address misinformation? So I will hand over to you, Simone, to respond to that. with 2 minutes.
Poor Felicity got an earful about this yesterday. So, okay, so I think one of the things, and this is, I'm very, very mindful, we get asked a lot about for vaccine hesitancy, right? And what is the misinformation, and people are hesitant. And I think we need to be really careful about what we're talking about when misinformation. Misinformation often comes from the responders, and misinformation might be because of the fact, as discussed with the or as explained with the Ebola symptoms, is that actually we were not providing correct information about what Ebola symptoms are. But what we look at in data, so the household surveys that were originally being done, not by us, were saying, well, do you know 3 symptoms of Ebola? So everybody was saying yes. So then, everybody could list 3 symptoms. So that wasn't the problem. So then they were saying, well, people aren't going to the treatment center, even though they know 3 symptoms. So there's a problem with community behavior. There's a problem with their issue. And actually, when we started to look at saying, well, what symptoms make you seek care? That's when we started to see that there's a gap between what are the most recurrent symptoms and what are the symptoms which result in healthcare seeking. And is that a misinformation that people don't seek care when they have a headache or a sore back? It's not actually misinformation, it's completely normal behavior. Yeah. When we look at vaccine hesitancy, all of the evidence from Eastern DRC indicated that people wanted more information. They wanted to understand things like why certain people were getting it and why other people were not. We worked really hard to say that communication campaigns said just accept the vaccine. So we have all these photos of posters that literally said nothing other than accept the vaccine. But then not everybody even got the vaccine. Like it wasn't even available for everybody. And so then we talked about rumors very quickly of like people were scared, there's rumors, there's this. And it was actually that we were not providing the information that was requested. COVID, exactly the same posters are all over the place, except the vaccine. Again, vaccine is not available for everybody. Again, did we look at the timing and the events of when the president said, I'm running out of time. Can I add one line on that?
Yes, please go ahead.
Yeah. So it's also important to understand what are the timeline of events. So when we say, well, then the president actually, said he was not going to get vaccinated with the COVID shield in the DRC. And then we say again, well, that's misinformation. And I was on a call recently where I reminded the donors that the president of the United States also doesn't use COVID shield and AstraZeneca. So when we look at misinformation, we want one country to behave one way with information that we want to provide them. And we do not control the fact that they have clear access to information of the fact that the vaccine here isn't eligible in France for a vaccine passport. The vaccine here isn't even distributed in the US. So those are information, they're facts. They're not misinformation. And they will influence behavior and engagement with prevention. So it's just about also thinking about what are we really defining as misinformation and why we use that term, and that we often do use the term to kind of community blame.
Yeah.
Absolutely. So CASS, we advocate to not do that.
No, I think that's such a important take home that I've gotten from the CASS and from listening to you over the past year or so as well, is really kind of reframing the questions, like looking at the data, questioning it, and really then seeing it through the eyes of the community too, and actually using data collection to really be action oriented as well. So through, for instance, your integrated questionnaires, really putting things in the greater context to understand really what the data means on the ground and how you can use that for the gaps, look at action oriented questions, and then really use that for program decisions. So I think that's really, really great to really reframe things always from the community perspective. So I think it's extremely powerful. And I think a lot of people on the call will think that too. So yeah, thank you, Simone. The next question we have from the chat is, this is more about, I think, really now thinking about application of the CASS and how this is really useful across the Eastern Europe and Central Asia region. If you were going to set up the CASS again from scratch, completely from scratch, e.g. in a different country, a different context, would you do anything differently? Would you add, would you change anything? Or would you keep the same approach and pop it in a different context? So I will start the class now.
Yeah, so absolutely I would change. I wouldn't have a CASS. I would have so what, as we did in Guinea, is an integrated outbreak analytics. So it's an integrated cell. Putting social sciences separately does not work. You need to be sitting together, and you need to get epidemiologists looking at social sciences data and social scientists looking at epidemiological data. And then not just that, socioeconomic data is huge, and it really influences healthcare seeking. It influences health outcomes. Separating socioeconomic data is also quite dangerous. So I would reset it up as an integrated cell, as we did in Guinea, as now we're looking at doing in CAR. I think it doesn't always have to be a cell. It can start off as a methodology. So for example, in CAR, I know, sorry, this is not the Asia region, but in CAR, for example, they want to do a 4-year program to reinforce all of healthcare systems and reduce overall negative poor health outcomes. What does that mean? That means right from the beginning, they want to come in, and another helicopter, I'm sorry. They want to come in and they want to, hopefully you guys can still hear me. They want to come in and have somebody come in and work first with government, bringing all the data sources together. You start off with workshops. You start off on thinking about what is the problem. When you have people looking at a common problem, that's where you can work together more holistically. The reason clusters and everything else can be challenging is because each one is doing their own objectives. The nice thing about health in some ways is if we have a common objective, we can then have a better integration. So if I was looking, I worked in Iraq previously, and we were doing community rehabilitation in areas post-Mosul in 2017. And same kind of thing, it was that thing of going, okay, first let's bring together all the different actors. Who needs data? Who's using data? Who's already got data? What does that data look like? And what is the key indicators that we want to use? Making sure very quickly that we were working with the local government in terms of accessing the community. But it doesn't always have to be a cell, but you do have to get the buy-in first from partners and local authorities.
Mm-hmm. Thank you very much. That was, again, perfect timing. You are so good at this. It's really, really impressive. There were some really, really great points there that I think will be extremely useful for people on the call. For me, it was really, how do you bring together different actors? How do you make sure you have buy-in from the very beginning? Really make sure they have ownership of the data. To really think about the gaps in the data as well, and what you really need to be collecting as well. So some really, really good stuff there, Simone. Thank you. So the next question I think we have here is, to what extent does this model need to be supported by external partners for it to be a success? If you were, for instance, to start off in a different country, do you think external partners are an absolute must, or do you think it could be done through other areas? I know you've already kind of touched upon this point a bit earlier, but if there's anything else you want to add?
Yeah, I mean, I think it's key. I mean, but what is an external partner? That's a different discussion, right? Like, I mean, a partner should be everybody and everything, and you can't let people out of the group. You've got to bring out everybody in. You've got to find ways to bring people in. We're developing training right now on what is integrated outbreak analytics. That training, well, I hired the person who will do that in Geneva. That person is being supported by CDC, MSF, Epicent, London School, Antwerp Tropical Medicine, WHO, and through GORN, the Global Outbreak Alert Response Network. If we don't have minimum that kind of buy-in, there's no way that MSF is going to start using that training. MSF is huge. They have people all over the place. Of course, we want them to be using that training, but we have to get them, get them involved at a country level. Same thing. So you can start small. You can start with certain partnerships, absolutely. But you really do want to be thinking of who are the people who have the most influence. So the reason why we collect data, right? The reason why we do studies is to influence program and response and do more accountable, more effective, and yeah, more appropriate, accountable, and effective response for communities. So communities need to be involved, but that might be, that communities are typically presented in local commissions or local NGOs as well. So how are you involving them? You can demonstrate success in like a small way and then get more people brought in, right? So sometimes you might not get the WHO being like, oh great, we're all on board, UNICEF as well, but you can get, I think we won over by first getting the NGOs using the data and then going back to UNICEF being like, guys, NGOs are using your data, our data faster than we are. Let's get going, right? And that kind of thing can also work, but so if you can show it at a granular level, it's success, then you can also expand it. Mm-hmm. But you need to be doing it in a way where we're constantly talking, constantly sharing, and trying to be as inclusive as possible. So we don't do anything that is not inclusive, or we really try not to.
Honestly, perfect timing. It's just brilliant. Honestly, I can't believe it. And so many great things there. What I love about that response is that you're using behavioral science almost as an approach to even like integrate this and really get it going, in the way you're actually getting buy-in and really asking, kind of making people feel like they're going to be left out, getting fear of missing out if they're not really using the data too. So good old FOMO. We have about time for about one more question. I actually have two really good questions left. So if okay with you, we'll stay on for two more questions. I know we're just about to hit time, but there's just really good questions left. Second to last question we have here, and of course, if anyone has any burning questions, please add them to the chat. We can try and make time, or I can speak to Simone afterwards and we can write, some type responses. But the second to last question we've got here is, what lessons have you learned on actually achieving political buy-in that could be applied to countries across the Eastern Europe and Central Asia region? So maybe we can think about in the DRC, how did you achieve the buy-in from the Ministry of Health, and how could that be applied to other countries across Eastern Europe and Central Asia?
Yeah, okay. So one, it took about 6 months for people to stop calling me an anthropologist and a risk communication specialist, yeah. Which as an epidemiologist hurts a little. It takes consistent patience. It takes knowing your audience. So if you're working in a Ministry of Health and you're working with a whole bunch of male medical doctors, and you are you're talking about communities and you're a woman, it can be very quickly dismissed, right? Let's be very, very honest about that. So it is about finding what your audience is looking for and finding ways of showing that to them first. And the moment you can show that you're on their team, the moment that you can show the use of evidence, that is huge. It also, I do believe that you need a level of seniority in UNICEF as well as in other organizations in the Ministry of Health. I mean, if we had come in with a very junior team, I think it also would have been challenging. You need the right people in your organization. So in UNICEF, we need the right people. And we were fortunate in the Ebola outbreak to have the head of the public health emergencies team in the Ebola outbreak there, watching this happen and then buying in and supporting it and going back to New York, going back to Geneva and pushing the model. But that kind of senior level buy-in as well, because they're also the people who will then make sure that in the Ministry of Health at the higher level, you've got them. If you're working with Ministry of Health and you're coming in with analytics, you need to be close to your head of health, your chief of health. Those kinds of things, they also really matter. Again, I don't know how many coffees or lunches or bilateral presentations or small adaptive presentations, or how many times I've listened to somebody correct my French, which is not obviously perfect, on a PowerPoint instead of look at the results and have to be like, okay, we change the French and we start again. Like, I mean, if you will, and you will, like, learning how to do a PowerPoint that people don't criticize for its visual is huge.
Well done. Obviously, so many points wrapped into those 2 minutes. That's amazing. I heard consistent patience, so important. Having a level of seniority, pushing the model from influential partners, making sure the chief of health is obviously on board and that the data is really being used as well. Some really great things there. All the way coming down, just making sure that you're not taking it to heart when people are getting at your linguistic skills. Although I've heard your French and it's pretty good. So there you go. Okay, we have our last question of the day, which I think is a good summary question. What lessons learned are there in moving from data collection to data use by key stakeholders? For instance, the inclusivity and design of the research, answering questions needed for decision makers, kind of triangulating and coordinating your data. So again, how do we move from data collection to actually data use by different key stakeholders?
Yeah, so first of all, I mean, in Ebola, we develop a tool and run a study in 72 hours and have data within 5 days, kind of thing. It's very rapid, but having people on the ground with the users consistently there means that there's an easy check-in, right? You're not going through long processes, but you are consistently checking in. Is the methodology something you're going to use? Because the methodology, especially in qualitative, people are like, oh, well, you didn't have it. It's not, understanding what saturation is key. So you have to make sure that there's buy-in on methodology, but then also that we're asking the right questions. So we've talked about this a lot we ask people, would you accept the vaccine? Yeah. What actionable, there's no action that can come from that. Whereas if you say, what information do you need to trust the vaccine? What information from who? What mechanisms would you need to be able to access the vaccine safely? There's action-oriented questions, and there's interesting to know, but not useful and potentially harmful to communities afterwards kinds of questions. So we need to go through every single question and go, how am I going to analyze this question? And how am I going to use the data? Qualitative and quantitative. It's obviously sometimes feels easier in a survey tool to say, well, how we're going to use this question, how are we going to use this question. Recently, we had the discussion of like, do we ever use employee? What do you do for a job? Do we ever use that? Do we ever analyze anything by that? And yet we continuously collect this question, right? So it's really being clear of like, people's time matters. Most of the time we're in communities that are very low income, that do not have time to be answering all of our questions all the time. So one, in terms of accountability, we need to know that we can use that evidence. Two, in terms of accountability to the response actors, we need to know that they are going to use the evidence. So we need to see that user first. Yeah. And so that user needs to be involved in the methodology, in the process, in the development of the questions, being willing to share it with multiple actors. So we don't talk about the user as being UNICEF WASH. We get it out to ACF, we get it out to WHO, we get it out to whoever else is going to use that data as well. And then again, presenting the data in a way that is looking at it holistically. So you cannot look at it outside of the epidemiological, sorry. You cannot look at it outside of the epidemiological reality. So people are not going to engage in vaccine prevention if they don't even see the disease around, or if the cost of transport has increased so much that they can barely afford to take a transport to get their child vaccinated. They would prioritize that over another vaccine. So really presenting data in a way that more holistically looks at the results also reinforces its use. And then showing people when they do use their data, when they do use it, going back and going, look at all the things that you did based on data, based on evidence, and then they can go to donors, they can go to partners, they can go to whoever they want to advocate, saying, look at how good we are. And that helps too, right? So making it very positive is also really key.
That was such a good response. It actually warms my heart to hear that response. Like really co-creation, really human-centered design, I think, in a lot of processes too. And making sure, as you said, the user, the person is at the center of all the questions when you're designing them, thinking about who they are, respecting their time, making sure everyone accountable to those community needs as well. And then, yeah, I think that was such a great response. And it really, as I said, warmed my heart to know that's happening. I'm sure it will do for the rest of the people on the call as well. Well, time is up. We've gone 5 minutes over, but I think we've gotten so much information in the past about 40 minutes or so. My brain is personally just kind of blown. So thank you so much, Simone. Honestly, your time is so valuable. So thank you so much for all these really interesting insights. It's really great to learn from you. And I know that the insights were really important, I think, for other colleagues on the call as well. For everyone on the call who is here, if you have any questions that have been unanswered by Simone, and please do share them on Backchat, and we'll make sure that we follow up as well to make sure that all the questions have been answered. We can do it in a written format, or I can get on a call with anybody as well. So yeah, thank you very, very much to Simone, and thank you to everyone who's joined. We can stay in touch on Backchat. We'll post the video of this on Backchat too. So yeah, thank you very much, everybody, and thank you again to Simone.
Thank you.
Okay, take care.
Thank you. Amazing session.
Thank you, Anna. Take care.
Thanks, Simone. Thanks, everyone.
Bye.